thanks for your patience on this rainy day. Glad to have you here. I have a quick few program updates first. And do you ever have a day just tired? Everything seems so hard. This guy's only like 1 inch. He's just crawling up this wall. It's taking forever. So maybe we'll just go to Italy instead. That's actually a famous dam. And no, those aren't snails. Those are goats. Isn't that just wild? That looks a little stressful. I'm really stressed and anxious. I mean, I wouldn't know how to get out of that predicament. So, never fear, we have Motivational Mondays here at our program. And we just got going, and we're getting going next month with a lot of fun activities. Tai Chi with Deborah, core and strength training with Clay, and yoga with Carrie Noto. So this is flashed up briefly on the screen. You'll get all the invites through my chart, but it's a great way for free to come and do exercise classes. Beginners are welcome. You don't have to be a pro. You don't have to wear anything special. And it's really fun just to kind of jazz up your Mondays. So we've got to jazz up our brains too, and we're going to start a book club. Woohoo! The first book has been sent out. Carrie is going to lead us fearlessly. It's a book written by Karen Koenig called The Rules of Normal Eating. So read it. If you can't come, read it, enjoy it anyway. And Kendall from Kendall's Kitchen is going to come and provide some really yummy, healthy appetizers. So that's an enticement. Sorry, no wine. And last but not least, more walking groups are being formed. So stay tuned, we'll be forming one at Seward Park. So that's my quick intro. I'm going to get things set up for our speaker. We're so excited to have Melissa Hull with us today, talking about all things lipid. And she is our director here at the Polyclinic for both our lipid clinics and our anti-coag clinics. So she's very wise. So come on over.
Okay. Well, thank you all for coming. Very excited to be able to be here with you and talk with you about all things lipids. It's definitely a potpourri of topics that I'm going to cover tonight, hopefully touching base on some things that you might be interested in learning more about. We're going to dive deep into quite a few different things, hopefully just to enhance what you've already learned through this program already. As Dr. Baumgaertel said, I work with the Anticoagulation Clinic and Lipid Clinic, and I'm a pharmacist by training. I'm also a clinical lipid specialist and have been helping within the Lipid Clinic for about 10 years. July will celebrate 10 years. And we work as a team. It's myself and a nurse practitioner, Jessica Durham, who's also a clinical lipid specialist. And our wizard behind the curtain, Dr. Hunegarth, is one of the cardiologists that leads up our program as well. So we're going to kind of give you a quick overview of what I hope to cover. I do welcome questions, so if there's things that you want to learn a little bit more about or clarify, please let me know. But tonight, the plan is to go over some of the labs that you might normally see with standard blood work, as well as some more advanced tests that we can do to learn a little bit more about your blood and your lipids. And then other labs in general that might contribute to risk assessment. We're going to talk through some of those. And then things that we look at in the lipid clinic. If you were to come see us as a patient, we're going to go over sort of what things we might consider to help assess what your risk might be for a heart attack or a stroke. And then we're going to go over some of the differences in the current guidelines. There's been some media reports recently and some updates and recommendations and controversies between those. So we're going to talk through some of that, as well as the strategies to help lower risk. Once we've identified what someone's risk is, we want to offer suggestions of how we can lower that risk. And a lot of you, I think, are working on those things. With Dr. Baumgaertel, we'll touch base on some of the medications and some of the new findings with certain medications, and maybe clarify some old news about the medications as well. So, does that sound fun? All right. So if you were to come see us in the lipid clinic, the things that we're looking for to estimate cardiovascular risk is pretty crucial. We call ourselves a lipid clinic, but our main passion is preventing heart attacks and strokes. That's kind of our end goal. We hope that we don't ever have to see Dr. Hunegarth as a cardiologist. We're going to try to put him out of business, basically. But we're going to look through some tests that you may have already done and maybe order some other tests. We're going to look through some diagnostic tests that maybe you have done. I'm going to talk through these things in a little bit. We look at your medical history, whether you've already had a heart attack or a stroke, or maybe another medical problem like diabetes or kidney disease, maybe an inflammatory condition that might contribute to your risk of having a heart attack or stroke. And then your family history as well. We want to look to what's going on with your mom and your dad, or maybe a sibling, to sort of give us a peer into your future about what might be in store for you based on those genetics that can happen. And then look to your lifestyle habits as well. What kind of things are you currently doing with activity and nutrition and weight management, and how that contributes to risk. So we start with what cholesterol is. It's basically a soft, waxy substance that's found in the blood. And it's generally a good thing. We do need some levels of cholesterol for our body to help formulate hormones and help our cells to function. The problem comes when we have too much. As with many things in America, if we have too much, it can lead to a problem. And same with cholesterol. So this is when it can start to build up into your arteries. Sometimes we can have trouble with a condition called pancreatitis due to excess levels of triglycerides. And I'm going to talk through more about what those are as well. But when we talk about cholesterol, we also need to talk about lipoprotein particles. Has anyone heard about lipoprotein particles? Too many. Okay. Yeah, get moving on. That's good, because lipoprotein particles are pretty important to the transportation of cholesterol. So cholesterol can become a problem when we have too much of it that's getting trafficked to our arteries and getting dumped into the artery wall. And the lipoprotein particles are responsible for carrying that cholesterol to the arteries, or where it needs to go to help with cell functions. Triglycerides are also packaged in these lipoprotein particles. So this is sort of an image. You can see that there's an outer shell, and then the inner core is where the cholesterol and the triglycerides are stored. So when we look to the lipid profile, we're looking at a variety of different lipoproteins, as well as cholesterol. So the total cholesterol is sort of the first number that you might see in your lipid profile. And it's basically the sum of both the good and the bad. So it's all the cholesterol that can be measured. It can be used to estimate risk. There are some evidence that the higher the total cholesterol level is, the more likely you are to have a heart attack or stroke. It's not necessarily a targeted therapy, and as a lipidologist, we want to know more than just your total cholesterol. We want to know what's making up the total, and looking deeper to the good and the bad. Hopefully you've heard that there's good and bad cholesterol before. The triglycerides are the fatty acid energy component of the lipid profile. Normally we want these below 150, and they can be elevated, contributing to a variety of things. So if you have a diet that's high in sugar, high in carbohydrates, high in fats, or even alcohol can have an impact on your triglycerides. Activity has a big impact on triglycerides. And if we get into levels above 500, that's when we're concerned for the condition called pancreatitis. So it can be a pretty significant condition and can be life-threatening. So if you have triglyceride levels that high, we're going to start looking at those first before we worry about anything else. HDL is the happy cholesterol. That's the good stuff that we want to generally be high. For men, we want it above 40, and for women, we want it above 50. And we think that this is a good thing to have high levels of it because it helps get rid of some of the bad cholesterol. But we're also learning with research that there may be some additional benefits that HDL has as acting as an anti-inflammatory process in the artery wall. We're going to talk through why that may be beneficial a little bit later. But HDL can be impacted by genetics, by smoking, by having a sedentary lifestyle, having a diet high in saturated fat or even trans fat can keep the HDL levels low. So the LDL is the lousy stuff. This is the one that we tend to focus on a lot. The lipoprotein molecule that is known as LDL actually carries most of our cholesterol. So this fight gets a lot of attention. We get high levels of LDL both from what our liver makes as well as from what's absorbed in the intestine. And that can come from foods that we eat or what's absorbed from our bile. The non-HDL is all the bad stuff. So I mentioned there's these lipoprotein molecules that are responsible for trafficking the cholesterol, and most of that's LDL. But for some people, particularly if you have high triglycerides or a low HDL, you end up with a higher level of non-HDL. Has anyone heard about non-HDL before? Okay. We still have some work to do in getting the word out about non-HDL. But it's a simple calculation. It's just your total cholesterol minus the good cholesterol. You're left with all the bad. So if most of your bad stuff is carried in the LDL, it really doesn't make that much difference. But if you have high triglycerides or low HDL, there may be a larger discrepancy between the amount of cholesterol carried in LDL versus non-HDL. So really this is the best number to look at with a basic lipid profile for assessing what your risk level might be for heart attack or stroke. And if you are targeting the LDL number as a goal, then we want the non-HDL goal to be 30 points above the LDL goal. So to simplify things, basically we're talking about dump trucks and trash trucks. The non-HDL is really all the bad stuff. It's carried by the dump trucks to the arteries. And then the trash trucks are the HDL molecules that help clean up the bad particles. This cartoon also depicts the importance of looking at other labs besides the LDL. It's just a cute caricature about LDL not being the only bad guy out there, that there's some other criminals we need to look at and to focus on reducing risk. So we're going to talk through some of those as well. So one of the biggest risk concerns that we'll look for is high blood sugar levels. So we know that having blood sugar levels above 100 indicates an abnormality and risk for heart attack and stroke. And this can be impacted both by what your liver makes and foods that you eat, genetics. A1C is another lab test that we can look to help us assess someone's risk related to development of diabetes or actually diagnosing diabetes. The A1C is a 3-month average of blood sugar levels. Has everyone heard about the A1C test before? Okay. We'll look to the thyroid labs as well because abnormalities with thyroid can impact your cholesterol levels. We look to liver function and kidney function to assess conditions related to inflammation or risk related to something called fatty liver. Ongoing chronic kidney disease can be a risk factor in itself for having a heart attack or stroke, so we look for that. And then vitamin D level is another lab that will assess. There's some evidence that very low levels of vitamin D may connect to possible cardiovascular diseases, and it can impact someone's ability to tolerate medications. So that's something that we look at as well. And then there are some advanced lipid tests that can be ordered. They're not done by standard labs. Our polyclinic lab can't run them, but we can send these out. We work with a company through the Cleveland Heart Lab associated with the Cleveland Clinic that can help us run some of these tests. And if we're real curious about those lipoprotein particles being a problem for someone, we can actually do direct measurements of them, and that's what this LDL-P number is. It's that particle number. And the ApoB is a protein that sits on the outside of those particles. So we can do a bit of a surrogate test measuring ApoB to see how many particles we may have. We can do a quick estimate with non-HDL. This is really the deep dive of things. So the Lp(a) that you see there is basically a genetic test that might give us clues as to why someone might be at risk for having a heart attack or stroke really early in life. So if you have a family history where your father or your mother has had an event in their early 40s or 50s, then we might look for this as more helpful information. Typically these tests aren't done in everybody, but they can be helpful for certain situations. There's also inflammatory markers that we can order to help us assess the sort of the state of your arteries and how much inflammation is going on there. The hsCRP is one that's probably most well known or talked about. It is fairly specific, but it can be influenced by things like other inflammatory conditions like arthritis or viral illness. But the second one here that we call the plaque 2 test is really specific to what's going on in your artery wall. So that can be really helpful for predicting risk of events. And then this last one here is actually a urine test that we can do to help us assess how much inflammation might be going on. So there's lots of additional numbers that we can look at to help assess someone's risk. And this is where the lipid clinic might come in to get more advanced testing done. There are some diagnostic tests that can be done to actually look for someone's risk of having a heart attack or stroke. What we're really looking for is whether or not you have plaque in your arteries already. And there's 2 tests that we can do that are called the subclinical tests that really are used to try to assess if you have plaque going on at the early stages, rather than waiting for you to have a heart attack or stroke to identify that there's plaque there. We can actually do some early testing. It's not covered by insurance. It's usually a test that you have to pay out of pocket for, but there are tests out there that we can order to look for you as an individual, whether or not you have this process going on. We can also look at tests that you've already had done, just going through your records and seeing with your mammograms or any other ultrasounds that you may have had if there's evidence of plaque there. And that does give us insight to whether or not your risk level is going to be higher than someone without. This is a really busy slide, but it's helpful with considering one of these tests called the Carotid Intermediate Thickness Test, which is basically an ultrasound test looking at the arteries in your neck. So if you've ever been pregnant and had ultrasound done of your belly to look at your baby, it's similar technology. It's a pretty specific type of ultrasound, but it actually gives us a measurement of thickness of the artery. And that's been used to connect to potential for risk of a heart attack or stroke down the road. And this study looked at 10,000 people and followed them for 10 years. And to see, based on their early assessment of what their artery thickness was, following them for 10 years, you can see the individuals that actually had disease present had a 40% chance of having an event in that next 10 years. Of those that had actual stenotic disease or blockages, which were seen, 81% of those patients went on to have a heart attack or stroke. So this could be really helpful information, particularly if you have a significant family history or other sort of unknown risk levels. We can use this information or do this type of test to help us assess what your risk may be. And this test is available out of pocket. It costs about $260. It's usually not covered by insurance, but it may be $260 well spent. So with getting all this information, what are we really worried about here? We're worried about the health of your arteries and the plumbing. So the arteries run throughout your entire body and are responsible for carrying blood to all your major organs and muscles. So we want to make sure that we are at risk for blockages in the arteries, that we're considering all the places that you might have this plaque. So if you have a problem in one area, you could be having a problem in another area. And the areas that we're most concerned about are the heart and the brain. So the heart attack is still the #1 cause of death in the U.S., and stroke's the #3 cause of death in the U.S. So even with all this information, we still have a lot of work to do. The stroke is actually the #1 cause of disability. So just to back up a little bit and talk through the description of arteries, I guess. We're worried about keeping your arteries healthy. It's important to know what we're looking for. So I have an actual model that I think is a little bit easier to see. Put the microphone down for me. Hopefully you can still hear. So this image does show the arteries that are supplying blood to the heart and what a normal artery would look like, as well as disease progression. So the model here also shows the same thing. So you can see that the top blood vessel there, that's a normal artery where blood is still flowing through without any problem. And hopefully you can see, I can pass this around too, that there are different layers of the artery wall. So if you take a slice of the artery here, there's an inner layer and an outer layer, and then a muscle layer in between. And if we get extra cholesterol floating around, it's going to get dumped in between these layers here. Not necessarily right on top, as some commercials for medications might depict. It actually gets embedded in between the lining here. And initially, our body's pretty amazing that it tries to adapt and it pushes outward so you can still get good blood flow going by. The diameter here hasn't begun to change yet. But over time, as more and more plaque gets built up, it can start to impede blood flow. And this is where you might see or start to have some symptoms of chest pain if this is in the artery supplying blood to your heart, or leg pain if it's in the artery supplying to your muscles down there. What we might be concerned about, besides the plaque that over time builds up and impedes blood flow here, there are some plaques that suddenly rupture, and that can be problematic for something that we call an acute event, where you might be fine one day and the next day have a major heart attack or a major stroke. And what can happen there is there's something called soft plaque that may suddenly rupture. And like with any disruption to your skin, yeah, that'd be great, thank you. If you cut your skin here, your body tries to repair that, sends in the white blood cells, the red blood cells, platelets, try to fix it, right? That same process happens once your artery wall, if you have that plaque that ruptures, your body's trying to fix the situation. You can end up with a blood clot on top of that location that causes an acute and sudden blockage of blood flow. So the next picture I have to show you, I will warn you, is slightly grotesque. It's an actual image of an artery taken from an autopsy showing an acute thrombus on top of a plaque that had been ruptured. So you can visualize what actually happens in your arteries. I won't leave it up there for too long, but it's a nice visual of what the process actually is. So you can see that the lining here has ruptured and then a blood clot has formed on top of that. So this is what we're trying to prevent when we look at all these things. I just wanted to spend a couple minutes reviewing sort of what to do if you are having a situation like this happening. Calling 911 is critical. Time to getting care is really, really important. 50% of deaths occur within the first hour of an event. So calling 911, getting help. I think it's very common for women in particular to sort of blow off these types of symptoms. We tend to think, we're fine, we can get through this. There's actually a really great video on the internet with a Hollywood actress depicting, I don't know if you've seen this, I can forward it to Dr. Baumgaertel for you all to see, showing this Wonder Woman of a mother trying to do everything in the morning to get her family up and out the door and having heart attack symptoms. And in each moment, she's just really kind of waving this off that this isn't happening to her. And I think for women in particular, it's hard for us to call 911 and think that this might be happening. So it is important that you do that. And for women in particular, our symptoms of heart attack might actually be a little different than men's might be. So men tend to have the more typical symptoms with chest pressure, chest pain, pain going down the left arm, shoulder, weakness, where women might have more atypical symptoms, being short of breath, maybe having flu-like symptoms, maybe nausea, maybe vomiting, or acute fatigue or weakness that could be going on. So if you have risk factors for heart attack or stroke and you've been working on preventing these things and start to experience these symptoms, please just call 911. You're much better off. Okay, so I'm going to switch gears again and go through some different tools that we have. Say we don't really have any information of any scans that you may have done to see if you have plaque in your arteries. Maybe you don't know about your family history or have a lot of additional information. There are tools out there that we call risk calculators, where we can plug in different numbers and measurements just get a prediction of the likelihood of you having a heart attack or stroke in the next 10 years. And the most tried and true scoring that we had for a very long time was called the Framingham Risk Score. And it looked at these different risk factors, and you could punch them in and you could get a risk prediction. We used this pretty consistently up until about 2013, and it did a pretty decent job. Unfortunately, it was based on studies that were done in Framingham, Massachusetts, on mostly Caucasian men. So if you're a Caucasian male, it did a really good job of predicting your risk. Unfortunately, that doesn't apply to everybody. So we found that if you were deemed to be high risk on this score and happened to be a man, it actually did a pretty good job of assessing that risk. If you came in high risk on this score, then you definitely were high risk. But if there are other groups that didn't necessarily fall into these categories that left us a little bit unsure, and particularly for women, we've also found that of the people that end up in the ERs and the hospitals with acute events, about half of them have only 0 to 1 risk factor. And so this tool may not always catch everybody. In 2013, the new guidelines gave us a new tool, which was based on data that included more women and a broader group of ethnicities, so it gives us a little bit better prediction. It also added the ability to not just look at your risk in the next 10 years, but your lifetime risk. So this is another tool that we can use. Basically, if your scoring comes in greater than 7.5% likelihood in the next 10 years, that's considered high risk. And so our treatment decisions might be altered if you fall into one of those categories. And it's based on some of the major risk factors that we talk about. Another condition that we look for in the lipid clinic when considering someone's risk is something called insulin resistance. Anyone know what that means? Heard that term before? Okay. Well, it's basically the underlying cause of diabetes. So type 2 diabetes is typically caused by your pancreas kind of running out of the ability to release insulin. And insulin is used to help our cells pull sugar out of the blood to be used for energy. And if those cells are resistant to the insulin, then it can't do its job anymore. And over time, the pancreas tries to pump out more and more insulin to help our body pull that blood sugar out of the cell, or out of the blood. And eventually, those pancreas cells sort of peter out, and we end up with diabetes. This process takes a long time for us to start to see the blood sugar start to go up. And before we actually call it diabetes, we can have damage going on to the arteries. And that inflammation that I talk about is sort of propagated and fueled by the blood sugar. And so we can have damage to our arteries before we even know we have diabetes going on. So this is something that we really look for clues for as someone comes into the lipid clinic to see if they're at risk for having problems with plaques and plaque rupture related to the underlying insulin resistance that's going on. And the old guidelines actually recognized this risk and recommended that we consider anyone with diabetes as having a very high risk of having a heart attack or stroke, a risk greater than 20%. We learned that that might not be the case for every single person with diabetes, that there are varying levels of that risk, but it is still crucial that we identify this early on. And if we can do that, we can actually impact people's health and outcomes, kicking them off the path of diabetes or kicking them off the path of a heart attack or stroke. It's a big problem for people that have diabetes. In fact, most people end up dying from a heart attack or stroke or some sort of vascular process if you have diabetes. So if only there were a way to identify people before they develop diabetes. There is. There's this system or group of risk factors that we call the Metabolic Syndrome. Has anyone heard this term before? Two of you have. Okay, good. So we've learned that if you have a multitude of risk factors within this table here, that your risk of developing diabetes and then a heart attack or stroke is definitely higher. If you have 3 out of the 5, that's considered positive for identifying the metabolic metabolic syndrome. So if you carry your extra weight around the middle rather than other areas, that abdominal obesity, that's considered a risk factor. If you have high triglycerides or on treatment for high triglycerides, and if you have a low HDL, if you have high blood pressure or on treatment for high blood pressure, or having a fasting blood sugar level above 100 is also a factor. And there's a study, this is from back in, I think, 2001. Let me get my slide to go. Oops. Come back to that one. That followed patients that had this constellation of risk factors and did show that they were 5 times as likely to die from a cardiovascular event, like a heart attack or stroke. So identifying this situation can be really helpful, be really motivating to having the lifestyle that we want. I'm going to go back to that slide that I passed over.
You know, the one that we were looking at, but we didn't finish.
This one here?
The risk factor.
Oh, back here. Okay.
I don't know how to interpret any of that. The only thing I could do on this would be to measure my waist.
Yeah.
The rest of them have no meaning.
The rest of them, you might need some assistance from the provider on getting the numbers. If you haven't had your lipid test done, looking at what your triglycerides are, your HDL, measuring your blood pressure and your blood sugar. But this slide here sort of talks to the fact that particularly if you have insulin resistance or metabolic syndrome or diabetes or wherever you're at on that spectrum, it's important to recognize that your metabolism and your processing of the lipoprotein molecules is likely different than someone who doesn't have that condition. And you probably don't have a lot of LDL cholesterol, that's the problem. You can have that non-HDL go up related to high triglycerides and low HDLs. And so it's important that we look at all the numbers and not just the LDL in particular if this situation applies to you. So if you think about if you're getting ready to go on I-5 and want to know about traffic and how much is clogging the freeway there, you're concerned about how many cars are on the freeway or how many dump trucks are on the freeway carrying the cholesterol, not so much how many people are inside the trucks and the cars. I like an analogy for comparing lipoprotein molecules versus the cholesterol inside. Does that make sense? Okay. So that can be an issue for people, particularly if you have underlying insulin resistance going on. There's another study that I like to share with people to look at the different risk factors that we consider. This study was done in 52 countries around the world. And among those 52 countries, these 9 factors were all consistent no matter where you lived. That if you had a heart attack, you are likely to have an issue with one of these. And the most common one was a ratio of bad to good cholesterol. So that was number 1. Number 2 was smoking. Number 3 was stress. Stress definitely has an impact on our risk. And then number 4 was diabetes, or sugar level. The last 3, the bottom 3, were found to be protective. So having a diet high in fruits and vegetables every day, having a high active lifestyle with lots of exercise, and a moderate amount of alcohol intake were all found to be protective in this study across 52 countries. So the last thing we kind of look to is our genetics. I mentioned before that genetics definitely play a role in our risk. They play a role in our lab values that we might see. There's some individuals that have very high levels of LDL cholesterol or total cholesterol. And these individuals tend to have heart attacks or strokes very early in life. So that's a condition that's called familial hypercholesterolemia. We do see some of these patients in our lipid clinic, and they really struggle with trying to get their numbers down. Often we have to use medications to help them. And the lipoprotein little a is another genetic test that we might look at to assess for genetics. The history of diabetes can run through families as well. There's a genetic disposition to that. So often it's a combination of our environmental factors, our lifestyle, on top of genetics. So we can't change our genetics, we focus on the things that we can change. I want to touch briefly on the different guidelines that have come out over the last 2 years. In 2013, the American College of Cardiology and American Heart Association came together to publish some new guidelines to how to manage cholesterol. We hadn't had an update since 2001. So we waited a long time for these guidelines to come out. And they actually made recommendations that completely shifted our philosophy of how we look at managing cholesterol and what we need to do for patients. So I want to just touch on that. There's been some information about that that's come out in the media. So I don't know if you've seen reports about it, and I wanted to walk through that to help your understanding of that. And then in 2014, a year later, the National Lipid Association came out with sort of a rebuttal to the 2013 guidelines, but they are more known as recommendations rather than strict guidelines. So I'm going to talk through the why of that, and then review a little bit about what the ADA is saying, that how we should manage cholesterol for people that have diabetes. So the 2013 guidelines, as I mentioned, really provided the recommendation that we should switch how we think about our recommendations to patients with managing cholesterol and risk for heart attack and stroke. And what they did is they brought together some experts and had some very strict criteria of how they were going to review studies, and looking at very large randomized clinical trials only, and particularly asking the question of who benefits from a statin medication. Most of the trials done at that level are with statin medications. And what they found was that there's basically 4 groups that benefit from statin medications, and that without a doubt, based on the trials that have been done and the high quality evidence that we have, these 4 groups would definitely have benefit if they took a statin medication. What they also looked at was how the studies were designed. And prior to this, our recommendations and guidelines had us setting specific LDL targets based on varying levels of risk that someone might have. And what they really called out is that the studies that were done were designed with a certain statin medication at a certain dose, not targeting a certain number per se. And so the patients that took this drug at this dose had a 20 to 30% reduction in heart attack or stroke. And so their recommendations are, if you fall into one of these categories, you should take a certain statin at a certain dose to get that benefit. So that changed what the previous guidelines had recommended for getting an LDL to a certain level based on your risk. So if you're someone who's already had a heart attack, or already had a stroke, or has known peripheral vascular disease, you would definitely benefit from being on a statin. If your LDL without medication is greater than 190, you would benefit from a medication. And they called out that the patients in these studies that had diabetes benefited from a statin medication, and they were in the age group of 40 to 75. So their recommendation is that anybody in that category would benefit. And the data is there. It does show that from those studies, those patients had a significant reduction in heart attack and stroke, as well as death. There's one study that actually had called out the patients that had diabetes who had a 40% reduced chance of dying when they were on statin medication versus someone who didn't. So that's what the evidence is saying. And then this last category are using that pooled cohort risk calculator that I went through before. If you have a 10-year risk greater than 7.5%, then you would definitely benefit from the statin based on the evidence that they reviewed. So as the world of lipidology, physicians are trying to digest what these guidelines are telling us, the National Lipid Association was hard at work trying to figure out how to help digest and help clinicians with the best way to get their patients to have a lower risk. And what they identified is that, yes, that's true, that data is there, we can't argue that data, but not everybody falls into that category. So they tried to offer additional recommendations of what we could do to try to lower risk if you weren't in one of those categories. Or maybe your body can't handle a statin medication. So that they offered suggestions of what other things you could do if those guidelines didn't work for you. So they basically went through the different risk levels and saying that the targets can still be helpful. And they highlighted the fact that non-HDL is probably a better target, particularly if you have insulin resistance going on. And that there is a role for medications that are not statins, particularly in people that can't tolerate the statins. So we're going to talk through that a little bit. And then in 2015, just this past January, the ADA came out basically supporting the 2013 guidelines, recognizing the data is there, that if you have diabetes, you are at high risk, and your risk is lowered if you take a statin medication.
And if you're over 75?
If you're over 75, they don't have specific recommendations for that. The studies didn't include individuals in that age category, so the evidence isn't there.
Oh, I was hoping it went away.
Yeah, unfortunately, we do know the older you get, the risk goes up. So we kind of infer that you would still have benefit, but it's an individual decision for sure. Okay, and then they also said for the category of patients that unfortunately we are seeing this rise in people developing type 2 diabetes early on, less than 40, even kids. So they're offering some suggestions that if someone is deemed at high risk with other risk factors besides having diabetes alone and are under the age of 40, they may still benefit from a statin medication. So let's talk about these treatments briefly. So this slide here goes through some of the medication options that we have as well as lifestyle. And I don't want to have you get the impression that this is not important. My focus of the talk today is not necessarily on lifestyle, but this is critical. And we can see really good reductions in cholesterol and these lipoprotein particles with healthy nutrition, activity, and weight management. So that's the first thing we're ever going to talk about in a lipid right before we go to medications. And exactly. But if we do need to go to medications, the statins is definitely going to be the most proven class of medications, and it's effective at lowering cholesterol, the lipoproteins, particles, as well as your risk. And it's really the only group of medications that's consistently in every study shown that it's going to lower your risk of both heart attack, stroke, and death. But these other medications may be helpful if this doesn't work for you. So niacin's an option. There's a group of medications called bile acid sequestrants, which work in your gut to bind up cholesterol and reduce absorption of cholesterol. And you can see a 20% reduction with that group of medications. Zetia is another option. There's older data, I think from back in the 70s, before we had statins, that the bile acid sequestrants can lower risk of events. And Zetia just, it was the end of 2014 maybe, where we had a clinical trial showing that in combination with a statin, Zetia did help reduce events a little bit. So we think it's a viable option if we need an alternative. Plant sterols can be helpful. This is found in different foods as well as some supplements. Omega-3s, the fish oils, can be helpful, particularly lowering triglycerides. They can actually raise LDL a little bit, but they can be helpful with triglycerides. So the statin medications, there's a lot of press about statin medications, and you're kind of either in one camp or another when it comes to statin medications. But I did want to talk through some of the information that we know. As I said, it's the best tool that we have based on the evidence that we have. It has the best support for that, actually reducing these events that we don't want to have happen. They've been around for quite a while, since the late 70s. Lovastatin was the first one, and it was actually based on red rice yeast. So sometimes we'll go to red rice yeast as an alternative, as it is basically a low potency statin. Statins actually work by acting in the liver to reduce the production of LDL cholesterol. And we think they have additional health benefits by reducing inflammation in the artery wall. They can also help stabilize what we call fibrous caps over the plaques. So if you remember that image before where we have that protective layer over the artery wall, they can help keep that stable and keep plaques from rupturing. So they can be pretty important right after someone might have a heart attack or a stroke to stabilize what's going on there. So there are concerns with statins, like with any medication. There are things that we have to be aware of and look out for. They are not without risk, although they are relatively very safe medications. The biggest concern with statins are muscle aches and pains. When you look at the randomized clinical trials of these medications, there was a low rate of these types of events. Only 1 to 5% of people reported them, but they did exclude a lot of people that might be otherwise at risk for that. So now that we have all this time and years of experience with it, it's really about 20% of patients actually can have muscle aches and pains on these medications. So it's our #1 reason for referral to the lipid clinic. I will say that with trial and error, we're often able to find one of these that you can tolerate, but there are still some people that ultimately we just decide we have to go another route. Liver damage has been a concern for many years with these medications, and up until recently, we were often following labs to assess someone's liver function when they started this medication, but the current evidence actually is showing that there's really no risk of liver damage. And in 2012, the FDA changed the labeling of these medications that removed that requirement for liver monitoring. So we really don't worry about your liver when you take this medication. It actually can be very helpful for some people that might have fatty liver. The enzymes can get better with starting these medications. So it's really no different than in the normal population. Diabetes, this is a newer finding with some of the more recent statin studies. It was discovered that the individuals that took the statin tended to have a higher, what they call convergence to diabetes, where their blood sugars went from early stages of pre-diabetes into the diabetes category. And with kind of retrospective analysis, it was discovered that the patients that had that occurrence were already at risk for that, but they already had, most of them had the metabolic syndrome, so we knew this underlying insulin resistance was there. There's something about the statin medications that pushes that forward, but the overall benefit of the statin medication still far outweighs this risk of having a little bit of a bump in your blood sugar. And individuals that don't have the metabolic syndrome or don't have the risk factors for diabetes, their blood sugar didn't seem to change with the statin medications. It's an interesting finding. It's something we do watch out for, but it hasn't changed our use of the medication. Memory problems or having a fuzzy brain is one that's probably the most perplexing of the side effects of statin medications. There's really sporadic case reports of this. It doesn't come out in the randomized clinical trials that have been done, but I've seen it happen in practice where people tend to have more trouble with word finding or just can't focus as well. And when you stop the statin medication, it gets better, it goes away. So it's a little bit tough to figure out for some people if it's really related to the statin or not. If we do a trial off the medication, we can usually figure that out. What's other interesting is that some of the studies included people that were at risk for Alzheimer's, and statin seems to be protective in that situation where less people have Alzheimer's if you take a statin medication. So the impact on the brain, I think, we still have more to learn about what's really going on there, but that's something else that you might hear about, statins causing memory problems. And it's usually not permanent. It's something that it can be reversed with just stopping the medication. So foundations for lowering risk. Once again, lifestyle is critical. Eating healthy, getting active, losing weight, not smoking, getting sleep, relieving stress, all of these things are all those criminals. They're all the bad guys that we want to make sure we're addressing and locking them up. The statin medications can be important. There's another group of medications that I'm not really going to talk about too much, but you may have heard of lisinopril or ramipril. They're blood pressure medications that have also been shown to reduce heart attacks and strokes and have some benefit on the blood vessel wall as well. And then aspirin can be important to preventing that blockage that happens with the platelets. So the bottom line is it's a lot easier to keep your artery clean and healthy than it is to reverse the damage that's already been done. So hopefully I've added to your knowledge today and given you that power to make changes and kick yourselves off any track you might be on for heart attack or stroke. I really appreciate you all having interest in inviting me here today. Thank you. I have a question.
Thanks for coming. Have a great evening. And I had a question actually. It seems like there's a lot of trial and error. You put someone on a statin, they don't like it or it doesn't work, and you try another one, and you try another one. And is there any way to predict, this whole new burgeoning field of, pharmacogenetics and how we can predict, what medicines might work for some and not for others? Could you maybe comment on that?
Yeah, definitely. So I think the world of pharmacogenetics is really booming, and I think we are going to have more assistance with that in time. We're just starting to scratch the surface of that. Right now, there's more theory about what works, and there's two statins in particular that are thought to be possibly better tolerated, especially if you've had muscle aches and pains. So pravastatin and Crestor, which is one of the brand name statins, it's still very expensive, but can be better tolerated for some people. The nice thing about Crestor too is that it is more potent than a lot of the other ones, so we can do small doses of it and get big results. And sometimes it's a dose effect where the higher the dose, the more likely we are to have the muscle aches and pains. So we can try the smaller doses and work our way up. But those are some of our strategies right now. There really isn't a whole lot of science at this point around what we choose. Sometimes we're effective and successful with assessing what patients, what your family history is, and if you have family members that have been on a statin medication that they've been able to tolerate, which is the genetics, but not the specific part of getting genetic testing done, but just talking to your family and finding out what they have tolerated. That's been helpful too.
Someone wanted off the statin completely, what would be your number one specific recommendation of what to do?
Of what to do with stopping the medication?
Well, being able to be taken off.
Being able to be taken off of it. I would say that I would want to know the risk of going off of it and what the chances would be of having a heart attack or a stroke without the statin medication, and weighing that out with benefits of being off the statin medication.
Okay, so, but more specifically, what could I do to get to the point to lower that risk? What would be your number one recommendation someone would do to lower that risk so it can be taken off?
Okay. So depending on the situation, you might still need the statin. But if you're really wanting to go without that route, we recommend a plant-based diet. Really removing animal proteins seems to have the best evidence of reducing cholesterol. It's hard to do, but some can really do it.
Okay.
That's our number one recommendation.
Do you need a physician referral to your clinic, or can people self-refer?
Well, actually,
Depending on insurance.
Right. We do take self-referrals. Self-referrals are seen by my partner, Jessica Durham. As a pharmacist, I have to have a polyclinic physician refer to me, but my partner, Jessica, can see self-referrals.
Would you review what inflammation is again?
Yes,
I hear that so
yes.
much and I have visions of it.
Yeah, so basically, I explain it best with a visual, so I'm going to put this down So when we talk about inflammation specific to the artery wall, so basically we're talking about inflammation at this level here. If you think about the protective layer here, it's kind of like a skin layer. So it's meant to be sort of tight and protective. If you have inflammation going on, those cells start to get expanded and they are less taut, for lack of a better word, and more likely to rupture. Yeah. And once that gets expanded, it's just less intact, and we can have more and more of those bad particles coming in, and the fire kind of gets fueled that way, and just stretches and stretches and stretches, causes that disruption. Anything to add to that from the physician perspective?
Yeah, I think I've been sensitive to, testing for inflammation, which is tricky. There was a time I think I did a highly sensitive C-reactive protein on everybody, and I kind of backed off on that because I realized anyone who has a arthritis or other inflammation, it just kind of skewed those results. So I guess it just underscores that there's so many other things, including inflammation, to think about when you look at someone's risk. So it's not just inflammation, but I think compared to even like 10 years ago, there's so much we've learned about it. So how can we control inflammation better? Probably all those things you mentioned, diet, exercise, moving more, being attentive to your, what you're putting in your system, maybe reducing, animal products, so to speak, getting your weight. I mean, all those things, of course, are health benefits, and I think they help reduce inflammation too. So,
Stress management.
oh my gosh, yeah, stress management. How could we forget? I bet you the next couple of years we'll learn more about, measuring inflammation and being more specific about that.
Definitely. There's a lot of really great research going on with different blood tests that can measure levels of inflammation going on. So, that help?
Yes.
Yeah.
Thank you.
Thank you so much. That was
Yeah.
wonderful.